Assalamu alaikum. I'm Dr. Abdurrahman Muhammad Alam. Welcome to today's cataract surgery insight into a black stone of a cataract. This is a 65 years old gentleman who has this black cataract, which is of grade 5 nuclear sclerosis. Main challenge in this case is to deal with the hard nucleus, and dividing this into smaller fragments is going to be a challenge. And the good part in this case is the cornea is extremely clear, and the visibility is not an issue, and the pupil is also very well dilated. So these are the good things which are encouraging. I have already stained the anterior capsule with Tryphene blue, which will help in the visibility while making the rhexis. For this density of a cataract, you should have a large rhexis for easy management of the nucleus. If you have a small rhexis, you will find various difficulty while managing the nucleus. In the video, we can see that I have accidentally raised another flap with the cystosome. This occurred because I have constructed a poor cystosome because I have bent the cystosome tip to 90 degrees. Thereby, I was unable to see the tip of the cystosome while I was constructing the rhexis. So I'll continue the capsulorhexis with the capsulorhexis holding forceps. Since it was a little bit on the intumescence side, I was unable to make a circular rhexis. It was somewhat a oval continuous rhexis. Now perform hydrodissection with small amounts of liquid. Now fill the anterior chamber with cohesive and dispersive OVT to form a soft cell technique. Rotate the nucleus with the Sinski. Keep on rotating the nucleus 360 degrees to loosen up the cortex. Now the biggest challenge is now to divide this nucleus into smaller fragments. In such dense cataract, my standard go-to technique is always to do a central trench or create a small central pit, which gives me access to the central core of the nucleus to perform a successful vertical chop. Now start with the modified chop. And the modified chop, I perform vertical chop where the settings are given in the left hand corner, where torsional energy is 40 and longitudinal energy is 60. The lateral posterior plate refuses to break. First ensure that the tip is buried, then start doing the vertical chop. Always ensure that the tip is completely buried and then attempt vertical chop, or you will experience nucleus torque and the nucleus will rotate and you'll fail to achieve a successful chop. This nucleus was chopped, but I failed to separate most of the chopped pieces at the posterior plate, which will make the nuclear emulsification in quad mode highly difficult. Now I'll start with the emulsification of the chopped pieces in quadrant setting. For emulsification, I'm setting the torsional energy to 100 and time on 400 millisecond and off time is 50 millisecond. I refill the entire chamber with cohesive and dispersive OVD to form a soft cell environment. Then I continue with the emulsification of the chopped pieces. While I'm emulsifying, I keep the Sinski above the nuclear piece to stop it from hitting the endothelium. Now I'll attempt to emulsify this large piece, which is comprised of multiple semi-chopped pieces which was attached to the leathery posterior plate. I attempt to chop but it is rotating, so I decide to emulsify the whole piece at one go. The piece was brought up into the anterior chamber and then I started to emulsify it. In doing so, I have sacrificed lots of endothelium while I'm emulsifying it. I'm trying to cut this large space into two parts by emulsifying the posterior plate, but still I find it difficult. Still, I'm finding it difficult to separate these two parts by scalping the posterior plate. Now I decide to refill the anterior chamber and the PC bag with OVD, thereby protecting the endothelium and the posterior capsule from the phaco tip. Here I'm placing the chopper in between the phaco tip and the posterior capsule, thereby protecting the posterior capsule from the phaco tip. You can also employ IOL scaffold method to protect the posterior capsule from the phaco tip by placing an IOL in the PC bag. This ball chopper has bravely protected the posterior capsule from the phaco tip. Thereby, no PCT occurred during emulsification of the nuclear pieces. Visco expressed the remaining fragments out of the S. Remove the cortex with coaxial iron hand. Now remove the subincisional cortex. A small bit of subincisional cortex is remaining. I fill the bag with OVD, pushing the posterior capsule posteriorly. I decide to implant the IOL, then I'll proceed to remove the subincisional cortex. Also, I made an incision at the conjunctiva to remove the trapped fluid to reduce the chemosis. Now I'm again attempting to remove the subincisional cortex, but I failed. So I decided to implant the IOL, then remove the subincisional cortex. Now the IOL is successfully placed into the PC bag. Now with the coaxial handpiece, I'll go behind the IOL and try to remove the subincisional cortex. Now I'm trying to remove the subincisional cortex, but still I'm unable to grab hold of the cortex. It is always getting loose and is not stripping off from the posterior capsule. I was unable to remove it. Again I tried, but it is not coming. It is very sticky. So I decide to use the aspiration port of the bimanual IA handpiece to remove the cortex while I'm irrigating the anterior chamber through the coaxial handpiece. Alhamdulillah, I was successful in removing the subincisional cortex. Now remove the OVD from in front and behind the IOL to avoid post-operative IOP spike due to retained OVD. Now perform stromal hydration of the side port and the main port, and the case is completed. Now inject intracameral antibiotic and subconjunctival dexamethasone. Thank you, my dear friends. Hope this cataract surgery insights into a black cataract was helpful in developing your surgical skills.